Now coming to the technique. As I told you, the first and foremost is always the primary anterior lateral portal. That is the primary wing portal which is actually utilized. For example, if it's the left knee, you will be going for the anterior lateral portal first and then anterior medial portal. But if it is for the right knee, you are going to the lateral of the right as well. So once you're done with that, then there are two ways of doing it. Some say going clockwise, other can go anti-clockwise. You've inserted the trocar of the anterolateral portal, and once you inserted the trocar, then you extend the knee and advance the trocar into the supralateral pouch of the patella. Once your trocar is there, then you can insert your anterolateral wing portal and bring it back in. Again, flexing the knee, you can insert your anterior medial portal. Once that is actually done, and you know it's your both portals and your trocars are actually in, and you know what is where your anterior medial trocar is, you can insert the trocar again, and once you retrieve the sheath out, then you can insert your portable instruments, which could be in form of a grasper, it could be shaver or whatever it is. Once that instrument is also in and camera is in, then first to perform is always the diagnostic arthroscopy. This is usually, you can do it by viewing it counterclockwise or clockwise, whatever the direction is preferable. But what is important is that you have to look at all the 9 compartments as a whole first. First, diagnose what is exactly the pathology. See everything else, just make it sure that all you should know what is abnormal and what is normal. And once you are done with it, then you go for some form of intervention. Best way is to start with the suprapatellar pouch. Once you are, because you're actually first viewing was over there, you can start with suprapatellar pouch, and that is with the knee in flexion, because at this stage the knee is in flexion. You can then go for the lateral gutter. You will look at the lateral compartment, and then you come all the way down towards the medial gutter. By this time it's in flexion, then you can extend the knee. You look at the medial compartment, intercondylar notch, as well as of the whole of the medial gutter as well. And once you are done with this, then again you can make a figure of 4 and look back as well as over the lateral compartments. The lateral compartment would include the lateral femoral condyle, the lateral meniscus, and the lateral tibial plateau and its cartilage. While the medial compartment will include the medial femoral condyle, medial meniscus, and as well as the medial tibial plateau and its cartilage. Once you have done all with this, then you can look into the intercondylar notch and view the ACL, PCL over there. If you are sure by this time, would be sure whether it's a meniscal pathology, whether it's the cruciate ligaments or torn, whether it's posterior medial compartment, posterior lateral compartment, is it problem with the cartilage on the medial lateral femoral condyle. Probably by the time you have performed the diagnostic arthroscopy, you'll be sure what exactly is the pathology. Nowadays, although we do not do this diagnostic arthroscopy straight away, we are very much sure by the time we are going in for the arthroscopy that what exactly is the diagnosis, because MRIs has advanced to such an extent, because beforehand you would have done your clinical examination, you have taken the history, you would be honest with if your patient had a history of giving way during a sporting activity, and then there was a twisting injury along with that, and when you examine the patient there was also Lachman anterior rod positive, you know it's ACL injury. So you, despite that, you know that it's ACL, and MRI has also given that okay, it's a grade 3 ACL injury with a mid substance tearing of the ACL. Despite that, once you go in for the arthroscopy, you have to perform all the diagnostic arthroscopy just to make sure that it's an isolated ACL injury. There's no associated lateral ligament or lateral meniscus or any other injury as well. And once you're sure that okay, it's ACL, then you can proceed with ACL reconstruction. Similarly, once you've done the diagnostic arthroscopy, and if it comes out to be a meniscal tear, then there are 3 basic ways in which you can repair. It could be all inside repair, which is usually not done nowadays, or it could be inside out repair, in which you're actually going through inside and then coming outside and stitching it outside, going with vertical mattress inside out repair, or we can go for vertical mattress sutures of outside in repair as well. Inside out and outside in was actually considered a gold standard, but nowadays the shift shifted to all inside surgery, and all inside repair is actually nowadays preferred treatment of choice for the meniscus injuries. Now once you have done that, sometimes the surgery could be, you don't need a repair of the meniscus. For example, if the meniscus, the outer 1/3 is actually the red zone, which can be repaired. Middle 1/3 is usually the red white zone, and inner 1/3 is actually the white zone. If the tear is in the inner third or middle third of the involving the white or red white zone, then actually the chances of the repair is very less. There is less likely that this repair would last, and eventually fibrosis would develop. Therefore, usually in that case, if it's involving the middle 1/3 or inner 1/3 of the meniscus, then the options could be in form of a partial meniscectomy, a resection of the tear, or complete meniscectomy, which is usually less likely done because complete meniscectomy has its own disadvantage, because it's actually there are a lot of hoop stresses which is actually occurring at the knee joint level, and this sort of they have a protective mechanisms for a knee, and therefore if the whole of the meniscus is removed, that would actually accelerate the arthritis at the knee joint. Therefore, for example, if the left knee arthroscopy is being done, the first and foremost is you have to go for arthroscopy and go for complete diagnostic arthroscopy. View it completely, view the injuries, whether it's the meniscus, whether it's the ACL, PCL, or it's actually the cartilage of the femur or tibia. Then once you're done with the diagnostic arthroscopy, you can understand, or you can decide whether you have to go put in the shaver through the anterior medial portal just to shave off the cartilage which is actually eroded, or you have to go for some form of microfracture technique, or you have to go for other techniques, that is the repair or resection of the meniscus. If you can appreciate it over here, you can appreciate this, actually tearing of the or teethering of the meniscus, in which you have to either go for repair or resection of the meniscus. Now, or you sometimes see is actually the loose bodies which can be appreciated over here. So these loose bodies just need removal, but then you have to go for all sorts, look for these loose bodies in all corners just to make it sure that all these loose bodies are actually removed, and there's no such loose bodies which are actually left behind. Sometimes this is what you see, that there's a cartilage loss as well as a problem with the femoral condyle. Microfracture technique is a sort of a technique in which it can be utilized to actually repair this cartilage loss which has occurred, and treatment of osteodeficans can be done arthroscopically. Or sometimes you see is this kind of a thing, the fraying of the edges of the inner 1/3 of the meniscus, and the simply meniscus can be resected, so that because this involves mainly the white zone. Therefore, nowadays, first you have to perform the diagnostic arthroscopy, confirm your clinical history, examination, and MRI findings, and you have to be absolutely sure that this is the injury, this is the only injury which was actually present on the MRI. And once that is done, then you can proceed with the definitive intervention of that pathology, whether the pathology is the meniscus, in ACL, PCL, or it's just in the synovium or containing loose bodies as well.